Thank you very much. It's a pleasure and an honor to be here presenting. And I bring you greetings from the Weill Cornell side of New York-Presbyterian Hospital, the other medical school partner of New York-Presbyterian. And I'm going to be speaking on sleep breathing disorders in children. And I want to give credit and thanks to two of my colleagues, Dr. Vikesh Modi, who's the chief of pediatric otolaryngology, and Dr. Allison Marish, who both of them have contributed to these slides and have contributed their expertise as well to this talk. So sleep disorder breathing is defined as the disruption of normal respiratory patterns in breathing during sleep. Sleep is very crucial to child development, and sleep disordered breathing, SDB, represents a range of disorders from mild snoring all the way to obstructive sleep apnea. Untreated obstructive sleep apnea can lead to serious health issues. But even without obstructive sleep apnea, sleep disorder breathing alone can disrupt sleep, affect behavior development, family dynamics, etc. The American Academy of Pediatrics estimates that 1% to 6% of children have obstructive sleep apnea. Many more than that have sleep disordered breathing. It's the recommendation that children and adolescents should be screened for snoring. If they snore, you should then screen for signs and symptoms of obstructive sleep apnea, which would include labored, paradoxical, or obstructed breathing during sleep, sleepiness, or hyperactivity, behavioral problems or learning problems. How do you evaluate for sleep apnea? Well, a polysomnogram or a sleep study is always helpful. It can diagnose the presence and the severity of obstructive sleep apnea. However, polysomnogram sleep studies are not always necessary in children, and I'll go through the current recommendations on this. We define pediatric obstructive sleep apnea by the numbers of apneas and hypopneas per hour. That's defined as the apnea-hypopnea index, or the AHI. 0 to 1 is classified as normal. 1 to 5 is mild. That should be greater than. Greater than 5 to 10 is moderate. And then greater than 10 is severe. These are different categories than in adults. Adults, you have to get to 30 apnea, hypopnea, or hypopneas per hour to be severe. In pediatrics, anything greater than 10 is categorized as severe. In addition to counting the apneas and hypopneas, the sleep studies gives you the lowest oxygen saturation, the percentage of sleep time below 90% saturation. It gives you elevations in CO2 level, tells you about sleep fragmentation and other sleep abnormalities. So if a sleep study is diagnostic of sleep apnea, why isn't it always necessary? Well, it turns out that the diagnosis can be very clear in many circumstances. You don't need a sleep study to diagnose sleep apnea in many children because it's obvious from observing the child. Also in sleep apnea, in kids, surgery can be absolutely curative. So we'll get into the recommendations in a moment, but this is very different from sleep apnea in the adult population, where in fact a diagnosis using a sleep study is required. In pediatrics, a sleep study is not always required. So I'll be talking about a clinical practice guideline that comes from the American Academy of Otolaryngology Head and Neck Surgery. The American Academy spends about 6 months developing each guideline. They're very iterative, they're very expensive, they're very formalized, they have experts in methodology that help create them, and they're strongly focused on what does the evidence tell us for best possible treatment. They're also multidisciplinary. If you have a pediatric obstructive sleep apnea clinical practice guideline, even though it came from the Academy of Otolaryngology, there's sleep medicine, general pediatrics, pulmonology, neurology, multiple different subspecialties are represented in all these clinical practice guidelines, and they're updated with new evidence every 5 years. From a practice guideline, you basically can get one of 4 possibilities: a strong recommendation, a recommendation, an option, or no recommendation. Strong recommendation means a treatment that is clearly beneficial with benefits exceeding risk and strong evidence supporting the recommendation. A recommendation means maybe the evidence is not so strong, not so perfect, or it means that maybe the treatment benefit risk profile is not so favorable. An option means either that the treatment is potentially risky, potentially exceeding the benefits, or it means there's poor evidence. So this is the cover, the title of the clinical practice guidelines on tonsillectomy in children. That was an update of a previous guideline. It was published in 2019. And these authors here, there's multiple authors from many different subspecialties. These are not all otolaryngologists. This is a multidisciplinary guideline which was sponsored by the American Academy. This guideline makes recommendations on several different things. It talks about tonsillectomy for infection, it talks about perioperative management, tonsillectomy for other indications, but it also talks about tonsillectomy for sleep apnea. And that's all I'm going to be talking about today. You'll see numbers on these recommendations. This guideline has many, many recommendations. I'm going to be focusing on sleep disordered breathing. There is a recommendation for tonsillectomy for obstructive sleep disordered breathing. Not necessarily sleep apnea. You don't need a sleep study to diagnose it. There is a recommendation for tonsillectomy in obstructive sleep disordered breathing in children. There's also a recommendation that you assess for important comorbidities, such as delayed growth, poor school performance, enuresis, asthma, behavioral problems. The recommendation for when to get a sleep study are basically twofold. Children less than 2 years old with suspected apnea, or high-risk groups, and we'll talk about the high-risk groups in a minute. The additional recommendation for a sleep study is if the need for tonsillectomy is uncertain or if there's a significant discordance between the exam and the reported symptoms. But if a child has clear obstructive apnea, witnessed apnea, and has enlarged tonsils or adenoids, you don't need a sleep study. You can go directly to tonsillectomy, adenoidectomy. High-risk patients, the guideline defines as the following: obesity, Down syndrome, craniofacial abnormalities, neuromuscular disorders, etc. So these are the high-risk conditions where it is recommended you do a sleep study before proceeding with tonsillectomy. And then this is tonsillectomy for children with sleep apnea, not just sleep disordered breathing. But the recommendation is that tonsillectomy and adenoidectomy is recommended surgery for children with obstructive sleep apnea based on the results of a study called the CHAT study, which I'll go through. Mild sleep apnea is a little bit controversial. However, most studies show benefit in healthy children. Also, what sort of outcomes assessment should you do following tonsillectomy? It's actually recommended that you do some outcomes assessment, but it doesn't mean you need to do a sleep study. There's complete resolution of sleep disordered breathing in 80% of healthy children, but you should be aware of high-risk groups. Now, this CHAT study was a very important study in the world of pediatric sleep. There had been no previous randomized control trials comparing adenotonsillectomy with simply waiting and seeing if the child would grow and outgrow the problem over time. But this was a large multidisciplinary randomized control trial which was published in the New England Journal of Medicine in 2013. And this is the title from that article, and you can see many, many authors, and there were other investigators involved in this study which were not even listed on the author page. The children were randomized to either have tonsillectomy, adenoidectomy, or observation, just to see if they would get better on their own. Children from 5 to 9 who had sleep apnea diagnosed on sleep study. All these children had to have a sleep study to be in this particular study. Excluded very severe sleep apnea, a large number of desaturations, significant comorbidity, children who also had recurrent tonsillitis or ADHD. And they did 7 months of follow-up, and they did several outcome measures. They measured executive function, behavior, symptoms of sleep apnea, quality of life, and every patient got a repeat sleep study in the tonsillectomy group and in the watchful waiting group. They randomized 453 patients. And what they found was there was no change in attention or executive function scores. However, there was significant improvement in behavior, quality of life, sleep apnea, OSA symptoms, and sleep study results in the TNA group compared to the watchful grading group. The sleep study findings normalized in 80% of patients in the TNA group and in 46% of the patients in the observation group. This is an interesting finding because, in fact, some of the observation kids did normalize. So there is a potential role for giving children a little bit of time, but the surgery group clearly did better. This is before and after. The second bar is after, and then the higher numbers are better in these. This is the children who are normal That's what the percentages mean here. And what you can see is that all the groups did better. However, if you were non-African American, if you were non-obese, and if you had milder sleep apnea, you did even better than the other groups. What's important is that the majority of the kids, now remember, almost 50% of kids with watchful waiting had normalization of their sleep study, but 70% of them remained symptomatic. They've remained sleepy. They had other symptoms. So the sleep study numbers got better, but they still had symptoms, hyperactivity, et cetera. And only 12% of the children that were treated with watchful waiting had no symptoms and normal sleep study. Only 12%, whereas 80% of the children with adenotonsillectomy had resolution. So the take-home message from this important study was early tonsillectomy, adenoidectomy is beneficial in behavior, quality of life, symptoms of sleep apnea, and also sleep study findings. You can consider watchful waiting in children with mild sleep apnea and mild symptoms. But TNA was found to be beneficial even in children with low AHI as long as they had symptoms. So that was the CHAT study. Now moving back to the guideline. The guideline recommends inpatient monitoring after tonsillectomy for high-risk patients only. You can do a tonsillectomy in a child with sleep apnea and send them home the same day. That's what the American Academy recommends, except in these higher risk conditions. That would be children less than 3, severe AHI, which means severe sleep apnea, which means an AHI greater than 10 or an oxygen dropping below 80%, or if they have any complex medical comorbidities such as Down syndromes, craniofacial abnormalities, et cetera. Otherwise, healthy kids over 3 with mild to moderate sleep apnea can actually be treated as outpatients safely. How do we do tonsillectomy and adenoidectomy? Well, what's really becoming more and more popular in the United States, and certainly what we do at New York-Presbyterian Weill Cornell, is we do tonsillotomy. We do partial tonsillectomy. The concept here is removing about 80% of the tonsil, but leaving a small rim of normal tonsillar tissue that acts as sort of a biologic dressing, which significantly helps with healing. There's several ways you can do this. You can do this with an electrocautery instrument. You can do it with a microdebrider. You can do it with a coblation, which is cold ablation, which is a radiofrequency technique. The advantages to this over total tonsillectomy is that it preserves some tissue and it avoids exposing the raw muscle in the throat, which then reduces pain, reduces the risk of bleeding, and also increases their oral intake quicker. The problem with you do a partial tonsillectomy is, what if that remaining tonsil tissue regrows? What if you have recurrence of the tissue, and then if you have obstruction, it could actually recur? Well, does it work? I will tell you, in my personal experience, I was taught to do total tonsillectomy. I did total tonsillectomy, and I taught residents for many years to do total tonsillectomy. Then my colleagues convinced me by showing me the data, and then I read more and more studies that actually partial tonsillectomy is better. So midway through my career, I completely changed. I'm now doing partial tonsillectomy in almost everyone, and I'm trying to convince people who are still doing totals that they're out of date, that they should be doing partials, because I used to do the same thing and thought I was doing the right thing. So here's some of the data on this. There's many, many studies that show that it works. It works both in symptoms and it works in sleep study findings. Compared to total tonsillectomy, there is clearly decreased bleeding, much a reduced ratio of decreased bleeding. In fact, sometimes we will go an entire year and not see a single post-tonsillectomy bleed at Weill Cornell, having done hundreds of tonsillectomies, not a single one. Whereas the risk of bleeding, postoperative hemorrhage after tonsillectomy, is about 2 to 5% with total tonsillectomy. They have decreased subjective pain, they use fewer pain meds, they return to normal diet quicker, they return to activity quicker, and they have fewer visits to the emergency room because of dehydration. The rate of regrowth is about 0.3 to 6%, but the rate of regrowth requiring revision surgery is much lower. It's as high as 2%, but actually in our experience, it's less than that. It's been less than 1% at our center. There was a 6-year follow-up study comparing total versus partial, and actually both groups did equivalently well. And this has been replicated in many other studies. Now, this is a video showing how we do the partial tonsillectomy. This is a microdebrider device. And what you can see here is, these are the tonsils, and the microdebrider device both removes and suctions the tonsil. And this video is just 2 minutes long, so I'll just let it run. But basically what you do is you remove this bulky protruding part of the tonsil, but you leave the part of the tonsil that's underneath the tonsillar fossa, underneath the tonsillar pillars, you leave that intact. And actually, as you work, you end up with something that looks like this. There's still some tonsil underneath that tissue, but then you stop. You stop removing any more tonsil, you just leave a rim of that tonsillar tissue. And then you take an electrical cautery instrument, and it'll show up in just a minute. You put a sponge in for hemostasis, and then you use a cautery device to electrocauterize the remaining tonsil tissue. But this is much less painful than cauterizing the muscle, which is underneath. And so kids tolerate this very well. In fact, kids are eating a normal diet the next day after partial tonsillectomy. And then what you'll see is the difference in these two sides. Instead of having this big protruding tonsil tissue, you have basically a normal looking pharynx. And then you can do the same thing on the opposite side. We use this same microdebrider for the adenoidectomy. You lift up the soft palate, you go behind the palate, and you remove the adenoids using this same microdebrider and cautery, and it works very well. Now, that all sounds great. You don't need a sleep study. Patients do great with a simple surgery. But what if it's not so straightforward? What if there is no tonsil adenoid hypertrophy? Or what if you have a child that has obstructive sleep apnea and you do a tonsillectomy adenoidectomy and it doesn't help? And remember, the cure rate was 80%. It wasn't 100%. So in fact, there are children who are not helped by tonsillectomy adenoidectomy. Well, what else could it be? It could be one of a variety of different syndromes. It could be a genetic syndrome. It could be a craniofacial abnormality. Probably the most common scenario that causes failure of tonsillectomy and adenoidectomy in these children is neurologic disorders, reduced muscle tone, hypotonia, general hypotonia, or other neurologic disorders that cause tissue collapse during sleep. That's probably the most common reason for failure. Allergies, upper respiratory, nasal obstruction, or another source of anatomic obstruction. Tonsil and adenoid hypertrophy is the most common source, but it's not the only source. We also have a relatively new procedure now called drug-induced sleep endoscopy, or DISE, that you can use to identify the source of obstruction. The ideal thing would be to put a fiber optic scope in a child or an adult when they're sleeping and see where the tissue is collapsing. The problem is when you put a scope in someone's nose, they wake up. So you can't actually scope someone when they're sleeping because they can't sleep with the scope in their nose. But what we do, which is the next best thing, is we give a short-acting basically sedative intravenous anesthetic, which puts the patient which puts the patient under, but they still have spontaneous breathing. So while they are briefly anesthetized with IV propofol or IV fentanyl or something like that, you basically go in with the scope and you look and see where they're obstructing. Now, there's some controversy in the adult world about just how accurate this is, because it's not really natural sleep, it's sedated sleep. But in the pediatric world, there's much less controversy. In fact, DISE is really believed to be quite effective at demonstrating the site of obstruction. So when you do this procedure, you can identify many times a hypopharyngeal mass, for example, a tumor. A common source of anatomic failure is lingual tonsil hypertrophy, which is rare, but it occurs, or an intralingual lesion. Glossoptosis, tongue collapse. Many times the tongue is anatomically normal, but it collapses much too far posteriorly during sleep, and that's the cause. It wasn't the tonsils or adenoids, it was the tongue collapsing. Sometimes it's sleep-dependent laryngomalacia or a floppy larynx, which is partially closing, and another common type is epiglottis collapse during sleep, and that's also called type 3 laryngomalacia. So with DISE, with drug-induced sleep endoscopy, you can actually do endoscopy on these children who are still having obstructive sleep apnea and often find the source of their anatomic obstruction, and many times it's surgically treatable. So you can correct those anatomic issues, or you can have weight loss, or quite frankly, you can put these children on continuous positive airway pressure, because that's not ideal to try to have a kid tolerate CPAP. On the other hand, sleeping every night with obstructive sleep apnea and oxygen desaturations and poor sleep quality, et cetera, that's a health risk for the child in addition to being a quality of life issue for the child and parents in terms of their daytime sleepiness, their development, et cetera. So CPAP is not ideal, but in fact, if you need CPAP, you're much better off with CPAP than you are having an untreated child with obstructive sleep apnea. Fortunately, that's rare. Most children with obstructive sleep apnea are treated either with tonsil and adenoid surgery or with another surgical procedure or with weight loss. But for that small subset that still have OSA, they still need treatment, and CPAP is the treatment of choice.
Dr. Michael, 5 minutes.
Thank you. So in summary, which won't take 5 minutes, you should evaluate for sleep apnea, but you don't need to do a sleep study. In children, you can evaluate for sleep apnea using a combination of symptoms and exam. You should evaluate for tonsil and adenoid hypertrophy. The most common scenario is a child with obvious obstruction and enlarged tonsils and adenoids. In that circumstance, adenotonsillectomy is extremely effective as being curative for obstructive sleep apnea. It's also very effective for children who just have snoring and sleep disturbance, but who do not meet the criteria for sleep apnea. Adenotonsillectomy is very effective at treating sleep-disordered breathing as well as obstructive sleep apnea. However, there is a subset of patients who have other etiologies of their sleep-disordered breathing. It's not always the tonsils and adenoids, and they don't always respond to surgery. And if that is the case, there are other treatments and other things that can be helpful. So again, I want to thank the organizers for the honor of participating in this conference. And this is a picture of the New York-Presbyterian Weill Cornell campus at night on the east side of Manhattan. And thank you again. I'll be happy to answer any questions. Thank you.
Thank you, Dr. Michael, for staying on time. Should we take questions now? If someone has a question. We'll do it after the session.
So I'm leaving because I'm judging the posters, I believe. Yes. Yes, sir.
Thank you, Dr. Michael.
Thank you.
I'd like to take your opinion about a new device that they are now using in adults, which is called the Inspire device.
Yes.
Instead of CPAP.
Yes.
And was this considered to be used in pediatric practice?
That's a great question. So the Inspire device, that's the brand name of the device. The device is a hypoglossal nerve stimulator that selectively stimulates the branches of the hypoglossal nerve that push the tongue forward. And this is a device which is surgically implanted along with a sensor in the chest that detects inspiration, and during inspiration, it stimulates the tongue to prevent the tongue from falling back. Inspire hypoglossal nerve stimulator is a game changer in adult obstructive sleep apnea. It is the first surgical procedure in adult obstructive sleep apnea that actually works 80% of the time. So it is actually an extremely effective treatment. Now, even it doesn't work 100% of the time, and there are certain indications. If you're too obese, if your apnea is too severe, if your obstruction is from another site, you're not a candidate for it. So in adults, it is fantastic, and it has actually enabled many people to have a surgical cure of sleep apnea. But it's not indicated in children. The child will grow too much. It's a series of wires that are attached to different areas, number one. Number two, so it's not been tried in children. It really isn't recommended in children because tongue collapse is not the primary source of apnea like it is in adults. Most children have a significant tonsil and adenoid and a different airway than adults do. And so, and I frankly don't believe it's going to become indicated in children. And it just has to do with the way it would have to be taken out in a few years and a new one put in. And so it's really not going to be, that particular technology is highly unlikely to be used in kids. Now, they are developing some new external nerve stimulators, which is basically a device you put on the outside for adults. And maybe for a tiny group of children who have some tongue neurologic problems, maybe we'll be able to use one of those external devices. But Inspire is for adults only. So, yes.
Thank you, doctor. My question is about long-term complications of sleep obstructive disorders, like right heart failure. Suppose a child goes undiagnosed for a long time.
Yes.
And say in the adolescence is when he's picked up and goes for a procedure. Is that too late? How much time does it take for right heart failure to develop?
It's a great question. And in fact, right heart failure, pulmonary hypertension, and all kinds of other cardiopulmonary morbidities are definitely occur with untreated sleep apnea over many, many years. We don't really know how severe the sleep apnea has to be or how long it has to last. We just don't know that. And there are patients who have severe untreated apnea who never develop those cardiopulmonary complications. But they do occur. We also know that people, children and adults with mild obstructive sleep apnea almost never develop those severe cardiopulmonary complications like pulmonary hypertension or right heart failure. But they do have, they develop hypertension and they have problems falling asleep. And for example, in the adult population, they have a much higher chance of unexplained mortality. For example, single car motor vehicle accidents. These people fall asleep at the wheel, they're so tired, and they have fatality accidents. So there's a lot of reasons to treat sleep apnea, but we don't know. So it is a risk. It's a reason you do want to treat it, but we don't know exactly how severe or exactly how soon it happens. Now, if the patient has reached the point of right heart failure, will doing a surgery to fix their sleep apnea reverse the right heart failure? Probably not, unfortunately. At that point now the cardiovascular system has been changed enough that it's probably not going to reverse the underlying problem. So it's better to do it earlier rather than get to that level of severity.
Some children have large tonsils, meeting
Yes.
in the midline protruding, but they have minimal symptoms.
Yes.
Do you suggest surgery for this group
Yes.
of patients?
Thank you for that question. I do not recommend surgery for children who simply have large tonsils but no symptoms. You shouldn't do surgery on asymptomatic patients in general unless you know that you have identified a problem which is going to create a problem later on. Many children with large tonsils, the child will grow and the tonsils will not. In addition, the tonsils tend to regress a little bit over time. The immune system is not as active when they reach their teenage and young adult years. So many kids and young teenagers who have large tonsils but do not have infections and do not have sleep disorder breathing, we do not recommend prophylactic or routine tonsillectomy. In fact, it tends to never be a problem later in their life. We used to take tonsils out all the time. In fact, many people remember back when people used to say, well, you know, your brother needs a tonsillectomy, let's just do the sister too, that way we can both recover at the same time, you know, and we don't do that anymore. So there's lots of people who have large tonsils that have never had them removed, and that's fine.
Thank you very much.
Thank you.